It gives me great pleasure to introduce you to KJ. Dr. Seung is a medical doctor trained in infection diseases and holds an academic position at the Brigham and Women's Hospital in the Division of Global Health and Social Equity. He has conducted research on treatment outcomes and side effects in MDR-TB patients who are co-infected with HIV. He began working for PIH in 2001 in Peru, where PIH started and scaled up MDR-TB program throughout the country. In 2007, Dr. Seung joined PIH Lesotho team to develop a comprehensive response to MDR and XDR-TB in Lesotho by request of the local Minister of Health. This program is the first community-based MDR-TB program in Africa, which utilizes a system of community health workers to support patients even in remote highland areas. So now I would like to give a floor to
I'm just going to turn on the webcam very briefly so I can say hello to you. The subject of my talk today is the development and amplification of drug-resistant tuberculosis. We'll have some questions, a few questions, about 5 questions throughout the lecture, and then we'll have some time at the end for answering some other questions that you type into the chat box. So let's get started. I'm going to turn off the webcam right now. Tuberculosis has been around for a very long time, and unlike other diseases, the older medical literature that was written about tuberculosis is still surprisingly relevant. Drug-resistant TB, for reasons I'll discuss later, was particularly important to scientists of the pre-Medline era. And the best definition of drug-resistant TB that I found is, which I have here on this slide, was by Denny Mitchison. When we say that a strain of tubercle bacilli is drug-resistant, we usually mean that a patient yielding such organisms would fail to respond to treatment with the drug concerned in normal dosage, i.e., a dosage that will cause a response in patients infected with sensitive organisms. So resistant TB is not a new phenomenon, and the early scientists understood that it was intimately connected with TB treatment. Again, the best explanations are from this early TB literature. So here's a quote from the British Medical Bulletin in 1954, also Denny Mitchison. Any sensitive strain of tubercle bacilli contains a few organisms which are naturally resistant, sometimes to high drug concentrations. They have risen by a process of mutation and are called mutants. When this population comes into contact with the therapeutic concentrations of either streptomycin or isoniazid, the sensitive bacilli are killed, whereas the few resistant mutants can multiply and eventually constitute the whole strain. That's what is depicted in this slide, in this diagram. So in the first culture, there are naturally occurring organisms that are resistant to isoniazid, rifampicin, and streptomycin. With streptomycin treatment, and remember this was the first TB treatment regimen, most of the susceptible organisms will be killed, including those that are resistant to isoniazid or rifampicin, but still susceptible to streptomycin. So it is only the streptomycin-resistant organisms that will multiply in the presence of streptomycin and eventually dominate. So in this way, you have created a streptomycin monoresistant strain. So while the mutants are naturally occurring, in order to select the mutants, you need to have treatment, specifically failed treatment. The earliest treatment regimens for TB would be considered woefully inadequate today because there were very few anti-TB drugs to choose from. They used pretty much all of them as soon as they were developed. At first, they developed streptomycin, so they use that alone. When they developed PAS, they use that alone or in combination with streptomycin. And with these very inadequate regimens, they found that the patients would respond clinically. The fever curve came down. You can see that actually in the top on the top line. The weight increased. That's in the second line of this diagram. The sputum and smear and even the culture would become negative. But as you can see in that fourth row, in the fourth line, the bacilli in the sputum starts to increase, and even the level of resistance, what would be called the MIC, that also increases. And at that point, the patient experiences clinical deterioration with the increasing fever and in bacillary load, and so this phenomenon is called the fall and rise. So there is a fall and then a rise in the bacillary load that is mirrored by the clinical response. So this is a classic pattern for development of drug resistance. It is how patients fail treatment, in fact. And it really shows the intimate connection between treatment failure and creation of resistance. By the way, some of these diagrams are quite small. If you go up to the top on the left, it says there's a button called full screen. And if you click on that, then it will expand it to your entire monitor, and you'll be able to read some of these diagrams more clearly. Now, in the decades really since, our understanding of these naturally occurrent resistant mutants has increased dramatically. So we know a great deal more about the specific genetic mutations that allow TB to avoid our drugs. Let me just give you one example with isoniazid, which is in the top row. So isoniazid is a prodrug that is activated by the catalase peroxidase enzyme called CATG. That enzyme is encoded by the CATG gene. So CATG generates a range of highly reactive species which attack multiple targets. If you have a mutation in CATG, and this is the most common mutation in isoniazid-resistant strains, these TB isolates lose the activity of this enzyme, and that stops the activation of the prodrug isoniazid. There's a less common mutation that is also associated with isoniazid resistance, and that's INHA. This enzyme is involved in the elongation of fatty acids in mycolic acid synthesis. If you have mutations in the INHA operon or the active site, this interferes with the ability to disrupt INHA. So those mutations in INHA they're less commonly involved in clinical isolates that have INH resistance, but they're still clinically relevant. And so that's just the story with isoniazid. So there are various genetic mutations that allow TB to avoid or block the action of each of these other drugs. And for each of those drugs and each of those mutations, the story can be quite complicated. As Dr. Mitchison said, these mutations are naturally occurring but rare. Pulmonary cavities contain about 10 to the 7th or 10 to the 9th bacilli. So they are unlikely to contain, they are likely to contain bacilli that have mutations that confer resistance to each of these drugs, isoniazid, rifampicin, ethambutol, and streptomycin. However, they are unlikely to have two mutations. So they are unlikely to have double resistance, for example, to isoniazid and rifampicin. It is therefore unlikely within a cavity to have naturally occurring multi-drug resistant tuberculosis, though you will have some bacilli that have isoniazid monoresistance, rifampicin monoresistance, ethambutol monoresistance, and streptomycin monoresistance. Again, our understanding of resistant mutations is much more advanced than it was decades ago, and it's really starting to uh, filter down to clinical practice, even in the settings where we work. So with new technologies, we can look for specific mutations that confer resistance. This is from the Hain website, where this line probe assay was designed to look for mutations in RPOB, which confer resistance to rifampicin, and to CATG and INHA, which are the main genes that confirm resistance to isoniazid. So let's go to question 1. A 56-year-old woman is a documented failure of first-line therapy for new cases. So that's the regimen formerly known as Category 1. So 2 months of isoniazid, rifampicin, ethambutol, and pyrazinamide, followed by 4 months of isoniazid and rifampicin. But she's a documented failure, so she has 2 positive smears in the last month of treatment. You send sputum for DST, and this is going to take, as we know, about 2 or 3 months to get any results back. What is the next most appropriate step in management? A. Do not start any TB treatment until DST results are back. B. Continue HR, isoniazid and rifampicin, that's the continuation phase, which is what she's taking right now, until the DST results are back. C. Prescribe 5 drugs, the regimen formerly known as Category 2. So stop what she's taking right now and switch her over to Category 2 regimen. And D, stop what she's taking right now and prescribe a standardized MDR-TB regimen, including second-line TB drugs. There are 2 most popular answers, and one of them is prescribe the Category 2 regimen, and D is prescribe a standardized MDR-TB regimen. So the correct answer in this case is in fact D. Now, the WHO no longer recommends the use of Category 2 in patients who have failed a Category 1 regimen. This, obviously, this comes with some caveats. This is in places where you have access to second-line TB drugs, access to an MDR-TB program. But in those places, the WHO does not recommend the use of Category 2 regimens any longer in cases of TB treatment failure. Now, why is that? This comes from the earliest days. The reason for this recommendation, this WHO recommendation, comes from the early days of TB treatment. So as I said before, back then, when there really was only 1 drug or 2 drugs, a lot of patients received monotherapy. And the results were clearly not good, even in 1954. So here's a table, patients being treated with streptomycin monotherapy, patients being treated with PAS monotherapy, patients treated with isoniazid monotherapy. They were really just trying all the drugs that existed at that time. And very clearly, the proportion of patients with failure and the proportion even more, the proportion of patients with resistant cultures, so developing resistance in streptomycin to PAS, to isoniazid, was very, very high. Higher for streptomycin and isoniazid than for PAS, but within 3 months, the proportion of patients with resistance to the drug used in monotherapy was, in fact, really quite high. So they understood even back then that monotherapy is the most effective way to create drug resistance. So the next step was, well, why don't we try using 2 drugs? And if you use 2 drugs, it's much, much more effective. You look at the first row, and again, the patients with resistant cultures is really quite high when you're using isoniazid monotherapy. But in the third row, that the creation of drug resistance and treatment failure is much, much lower when you're using streptomycin and isoniazid in combination. But you see the problem here in the fourth row. Now, obviously, the sample size is really quite small, but if you use streptomycin and isoniazid in a patient that has failed treatment already with streptomycin monotherapy, and because of that has already developed streptomycin resistance, these patients fail and develop isoniazid resistance just as if they were taking isoniazid monotherapy. So even though even though you're using a two-drug regimen with isoniazid and streptomycin, because of the pre-existing streptomycin resistance, you are prescribing effective monotherapy. So this is the basis of that famous edict, never add a single drug to a failing regimen. So I think most people are listening to me will say, well, this is quite obvious. In this day and age, who is going to be stupid enough to use monotherapy? I mean, first of all, doctors have the benefit of all of this previous experience in research, and there are also systemic controls, such as the use of fixed-dose combinations, that have been put into place exactly to prevent gross medical errors, such as adding a single drug to a failing regimen. Unfortunately, the Category 1 regimen and the Category 2 regimen differ by exactly a single drug. The Category 2 regimen is supposed to be used in retreatment cases, and really, retreatment cases in all countries include failure cases. So if you go, so in many countries still, Category 2 is still used for failure cases, failures of Category 1. And prescribing Category 2 after failure of Category 1 violates this edict. Never add a single drug to a failing regimen. And this is the reason why WHO has modified these recommendations. In the more recent guidelines, this will be with a caveat, this failure here, saying that in places where you have an MDR-TB program, that you have access to second-line drugs, failures of Category 1 should not move on to Category 2. They should receive an MDR-TB, an empiric MDR-TB treatment regimen. Now, we don't know, of course, that all Category 2 patients have drug resistance. Defaulters and relapsers after Category 1 are more likely to have pan-susceptible TB than the failures are. But all of these categories of retreatment can have drug resistance. So keep in mind that none of the standardized DOTS regimens, the first-line anti-TB drugs, so meaning the former Category 1 and Category 2, were designed to treat drug-resistant tuberculosis. And that's why there is very little data about the efficacy of Category 2, despite the fact that in most countries, 10 to 20% of all TB patients are receiving Category 2. So there was a recent systematic review of the efficacy of Category 2, and the authors wrote about the lack of evidence for Category 2. They said the most striking finding of this review is the remarkable lack of evidence in support of the WHO recommended retreatment regimen currently used to treat as many as 1 million TB patients every year. The current body of evidence for treatment of previously treated patients is a dog's breakfast. A few cohort studies in patients with pretreatment drug sensitivity testing, a limited number of randomized trials in previously treated patients, and many small subgroups with initial drug resistance included in trials of new cases. Shall we go to question 2? A 34-year-old woman is diagnosed with her first episode of TB and prescribed a Category 1 regimen. 4 months later, her DST results, which were sent at the beginning of treatment, come back with resistance to isoniazid and rifampicin. 2 sputum samples are smear negative right now. The patient says she is clinically asymptomatic and has gained weight. What is the next most appropriate step in management? A. Continue HR for a total of 6 months. She's at the 4-month mark right now, 2 months more, and she would be done with category 1. B, send sputum for culture and DST. C, prescribe a category 2 regimen. D, prescribe a standardized MDR-TB regimen. So I think that here, there are two most popular answers. One of them is send sputum for culture and DST, ostensibly to confirm the diagnosis of MDR-TB, and D, which is prescribe a standardized MDR-TB regimen. I think you can make good arguments for both of those. I remember that when we treated this patient, we also debated within our team about which of those is correct. So I don't want to say that there's a right answer, but there's definitely a wrong answer, and that would be A or C. Some people would say, and it's very interesting, some people even on our team argued, why are you so worried about this laboratory result? It's inconsistent with the clinical picture. If the patient really had MDR-TB, she wouldn't have improved clinically. But this is actually not true. The laboratory result in this case is completely consistent with her clinical picture, with her clinical improvement on category 1. Let's look again at the fall and rise phenomenon here in a diagram form. It's labeled with isoniazid monotherapy, but it's just as accurate if it was labeled 2-drug treatment with ethambutol and pyrazinamide, which is kind of what this patient received. So what happens if your MDR-TB is treated with ethambutol and pyrazinamide? The bacillary load is going to fall. The patient will feel better. The fever will go down. The cough will get better. The weight will go up. So the clinical improvement of this patient is consistent, in fact, with the treatment of primary MDR-TB with a category 1 regimen. And so this is one thing that is very important that I always tell new clinicians on the MDR-TB team. The fact that there is clinical improvement in category 1 and category 2 does not rule out MDR-TB. Now, of course, once you have evidence of drug resistance, in this case, this is laboratory, you do have to work it up. I can tell you, I personally didn't believe the laboratory, so I ended up sending 2 more sputum samples, in fact, to 2 different laboratories. And both of those samples were smear negative, culture positive, and resistant to isoniazid and rifampicin. Now, one of the reasons that many clinicians are still confused about what happens with MDR-TB treatment by category 1 and category 2 regimens is that there was a time when we thought that these regimens, these short course chemotherapy regimens, were pretty good treatment for MDR-TB. So this is a rather popular article in the year 2000. Here, the authors looked at the subset of MDR-TB patients that were incidentally found during a WHO Union global project to do drug resistance surveillance, and they picked 6 countries. These patients were all new patients, so they had never been treated for TB before. Presumably, this was primary MDR-TB. And of course, once you're diagnosed by smear, you would get the 6-month standardized regimen, the DOTS regimen, category 1. The DST for the survey was done later, and in most cases after the patients had finished treatment. So they could go back and say, what happens if these new MDR-TB cases are treated with category 1? And what they found was that the cure rate was pretty good. So in Korea, Peru, and Hong Kong, the cure rate was 54 to 59%, and that's probably better than you could do even with if you had second-line TB drugs. and in many places you didn't. So what was the explanation for this? The flaw was that the treatment outcomes were designated by smear microscopy. And we know that the fall and rise that happens when MDR-TB patients are treated with an inadequate regimen, that this produces a fall in the bacillary load. But this is a transient decrease. It's not a durable cure. And we would expect that bacillary load in their sputum to rise once the treatment is finished or once the new resistance has been selected by that inadequate regimen. And that is what multiple studies have shown since then. If you take those cured patients, those 54% of cured patients, and you follow them out for months afterwards, as they did here in Uzbekistan, they found that these, that all of the drug-resistant TB patients, in particular the MDR-TB patients, have a high rate of relapse. So that the MDR-TB patients at the end of 18 months of follow-up, about half of them have relapsed again with tuberculosis. And the interesting thing is that if you go back to the original MRC trials of short course chemotherapy, they also there found a few cases, not that many, but they did have some small numbers of patients with drug resistance. And these numbers, even though they are small, especially the one for rifampicin resistance, it is suggestive of much higher rates of failure, uh, and also with subsequent relapse, even in those who have been ostensibly cured. A 22-year-old woman is prescribed category 1 after being diagnosed with her first episode of TB. After 2 months, you extend the initial phase by 1 month because she is still smear positive. And this is a common practice in many countries. After 3 months, she is still sputum smear positive. She's weak, tachypnic, and needs to be hospitalized. What is the next most appropriate step in management? A, extend the initial phase to 4 months, so 1 more month. B, switch to the continuation phase of category 1. C, stop category 1 and prescribe category 2. And D, stop category 1 and prescribe a standardized MDR-TB regimen. So in this case, I think we have clear consensus with the group. And the correct answer is clearly D, stop category 1 and prescribe a standardized MDR-TB regimen. This patient does not fit, however, the program criteria for treatment failure. So in your countries, in the countries where I work in, this patient is not called a treatment failure. So this is actually very interesting that most of you, the vast majority of you, would say that you would call her a treatment failure and prescribe a standardized MDR-TB regimen in violation of your national guidelines. But from a clinical point of view, this is clearly the correct answer. So we know that sputum smear positivity at the end of category 1 or 2, so a programmatic treatment failure, is highly suspicious of MDR-TB. There have been multiple studies, so Peru and Vietnam, just to name a couple, that show that over 80% of these types of patients have MDR-TB. As I said before, relapsers and defaulters, they do have MDR-TB, but is not as high as treatment failure, so smear positive at the end of category 1 or category 2. So one interesting point is that we have thought that these patients have acquired MDR-TB during the course of failed treatment. But it turns out that many of them were actually infected with MDR-TB from the beginning. because we don't do DST at the beginning of treatment, we usually only do it when the patient has failed or relapsed, that we can't recognize this. If this is true, in fact, category 1 failure is just unmasking the MDR-TB rather than creating it. So that raises a question. Is it possible to unmask or to diagnose or to suspect MDR-TB more quickly than at the end of category 1 treatment? So this table, this graph comes from Peru. This is a retrospective study. The authors looked at the sputum smear results of two groups of patients, the cases and then the controls in the dotted line. The cases were culture positive. They fit the programmatic definition of treatment failure, culture positive at the end of treatment. The dotted line, the controls, fit the definition of culture negative at the end of treatment. So if they look actually in Peru, they often do smears throughout the treatment course, so monthly rather than only at month 2. So they're able to see what happens in these two groups of patients. And what's interesting is that in those who go on to cure, even at 1 month, the percentage of patients who were smear positive is only 10%. By month 3, this is almost 0. So really, if you're looking at a patient, and like the one we discussed in question 3, who's smear positive at month 3, this is a very, very high suspicion for MDR-TB. The other thing that you really notice here, again, is the very beautiful fall and rise, that the numbers of the failures who were positive at month 4, so late in treatment, is actually more than those who were negative at month 2, for instance. So the bacillary load goes down and then comes up again, just as the early scientists described. This is a more complicated study, also from Peru, but this is a prospective study that followed patients with smear and culture at regular intervals at the first 2 weeks. In fact, I think it was at 15-day intervals and then later at monthly intervals. There is a big difference here in culture conversion between the drug resistant and then the drug susceptible strains. Drug susceptible strains, fully drug susceptible strains, are largely 90% culture negative at 2 months. However, the culture conversion is much later, much slower in drug resistant patients and never happens at all in the MDR-TB patients. The problem here that I'd like to point out is that a surprising large proportion, so almost a third of the MDR-TB patients, are actually culture negative at the end of treatment. This is again because of the fall and rise phenomenon. So what this shows is that the failure to convert your smears or cultures is a very strong indication of MDR-TB, and you can probably pick this out even earlier in treatment than what we commonly do. So maybe even at the 3rd month, maybe even at the 2nd month in some patients. But the converse is not true. So if the patient is negative, we cannot assume that the patient does not have MDR-TB. There is a question here saying, shouldn't there be another choice in question 3 saying that you should start category 2 and send the sample for culture and DST? Well, hopefully this question can answer that question. A 50-year-old man is prescribed category 1 treatment after being diagnosed with his first episode of TB. He is in the 5th month of treatment and his sputum is smear positive, but he is clinically stable. You receive his DST results sent at the beginning of treatment, and they come back after several months delay, and they show isoniazid monoresistance. What is the next most appropriate step in management? A. Continue HR for 1 month. B. Stop HR and prescribe REZ for 9 months. C. Stop HR and prescribe category 2 regimen. D. Prescribe a standardized MDR-TB regimen. This question is confusing. So I think here, again, it's hard to the I think that the top two answers, the most popular answers, is B, stop HR and prescribe REZ for 9 months, and D, prescribe a standardized MDR-TB regimen, and maybe a bit skewed towards REZ. So the confusing, clearly the confusing part of this question is the DST, because if there was no DST, uh, most of you would say, like the other patient in question 3, patient is a failure. He's a programmatic failure category 1. So we should send a DST and prescribe now a standardized MDR-TB regimen. In fact, it would be overkill if he has isoniazid monotherapy to prescribe an MDR-TB regimen. A lot of you here in the questions are worried about the cost. You don't need to, this patient can be treated adequately with rifampicin, ethambutol, and pyrazinamide for 9 months and doesn't need an MDR-TB regimen. But this would be a mistake because remember, if you read the question closely, the DST results were sent at the beginning of treatment. They haven't been sent now at the 5th month of treatment. This has been 5 months that the patient has been on a failing regimen, and this is ample time for the patient to develop more resistance on that failing regimen. So this is one of the pitfalls of using DST, is that often in we are several months late. And the problem, as we know, is that from our previous discussion, is that patients develop resistance while they are on failing regimens. This is a study, a very well-known study from Vietnam, where they looked at patients who had failed or relapsed after receiving their category 1 regimen. Now, the first thing they found was that a high numbers of these patients, so 80% of these patients had MDR-TB. Um, I'm sorry, the failure patients. Among the relapse cases, the MDR-TB was much less common, about 8%. But of these, they looked at these MDR-TB patients. This is after failure relapse. And then they looked at what resistance pattern did they have at the beginning of treatment. This was a study where they banked the sputum samples from the beginning of treatment and then compared them with the DSTs that were done after failure. And what they found was that many of these patients had started with much more benign resistance patterns uh, before treatment, and then had been turned into MDR by this failed course of category 1 treatment. In fact, most of them, so 68% of the patients who had other drug resistance ended up developing MDR-TB while on category 1 treatment. And this is commonly known nowadays to be the amplifier effect of short course chemotherapy. So the danger here is that by strictly following WHO guidelines, giving category 1 in a relatively benign resistance pattern of polyresistance, and as the patient fails treatment and receives multiple courses of category 2, the resistance pattern also becomes much more dangerous, much more difficult to treat, and much more of a danger to public health. In the 2004 drug resistance surveillance report, the WHO made this actually quite clear that amplification of resistance is one of the driving forces in the drug-resistant TB epidemic. Lastly, we have seen that monoresistant isoniazid and streptomycin, double-resistant isoniazid and streptomycin, triple-resistant isoniazid, streptomycin, rifampicin, and quadruple-resistant isoniazid, rifampicin, streptomycin, and ethambutol cases account for 85% of all resistant cases. This suggests that globally, as well as in most regions, the main pathway of drug resistance amplification is HS monoresistance, HS polydrug resistance, HSR multidrug resistance, and quadruple resistance HSRE. Other pathways can and do exist, but their contribution to the drug resistance problem is relatively minor. We can therefore state the monoresistance to H or to S is the foundation for the acquisition of additional drug resistance. The above analysis has shown that there is circumstantial but compelling evidence that either monotherapy or effective monotherapy, as you see this phrase that we discussed earlier today, or both are more widespread than commonly thought. These results corroborate recently emerging evidence that standard retreatment regimens containing first-line drugs for failures of standard treatment should be abandoned in some settings. So this is really one of the answers of why it can actually be cost effective to use MDR-TB regimens in earlier rather than later after another round of category 2. So you have drug resistance that exists in the population. These drug resistant strains go through inadequate treatment with DOTS category 1 and category 2 regimens. The problem here is that there is amplification of those resistance patterns. So more complicated, more difficult resistance patterns are created. And the public health danger is that those strains are then transmitted to other people. And then the cycle continues. I am going to skip question 5 since we're running out of time, and I'm just going to go to my conclusion, which is that drug resistance is due to naturally occurring genetic mutations, but treatment errors select mutants which grow into resistant strains. Amplification of resistance is acknowledged as an important driver in the creation of resistant strains, which then can infect more people and completing this cycle. And finally, that treatment errors are common. This include adding a single drug to a failing regimen. So, for example, prescribing category 2 for failures of category 1. Failing to recognize and diagnose drug resistance in a timely manner. So, for example, not recognizing the signs of treatment failure. And treatment with an inadequate regimen. For example, prescribing standardized first-line regimens for patients that have undiagnosed or unsuspected MDR-TB. Thank you very much. Why don't, in the time that we have left, so please feel free to write some questions, and I'll answer some of the past questions, previous questions that have already been answered. So there's a question that says, how long does it take to acquire resistance to drugs to which he is susceptible? So how long does it take for a patient to develop resistance to a single drug or to 2 drugs if they are in the regimen together? Now, clearly we know that, so this question is not been answered. We don't know this even in clinical practice because many patients who we think are being treated with 4 drugs, for example, as in category 1, may be getting effective therapy with less if they have pre-existing drug resistance. So it is difficult to tell how long it takes to develop drug resistance. Clearly, some of the best evidence comes from those early trials where they use monotherapy. I can tell you even um, uh, that I have seen patients develop drug resistance with monotherapy or effective monotherapy even much more quickly than 3 months or 2 months. Those guidelines, for example, that WHO, those definitions for default, for instance. So I think that uh, with monotherapy, uh, resistance can develop very quickly and is difficult to, but with when you're using combination chemotherapy, it's probably less quickly, but we don't really know exactly how fast resistance can develop. So it's less useful as from a clinical point of view to worry about if the rapidity in which drug resistance is created, but in fact look at criteria for suspicion of drug resistance. For example, smear or culture positive during a course of a failed treatment. There were a number of questions here about is is it cost effective to use to offer empiric second line treatment rather than to just screen for MDR-TB and start a second line a category 2 regimen. To me, it would be more cost effective to give the patient nothing and then wait for DST results than to start a category 2 regimen. That when you're thinking about that starting a category 2 regimen in a patient where you suspect that there is drug resistance or MDR-TB, that is there is a danger of amplification of that resistance pattern. So for that patient, you're really doing a disservice. And even for the cost to your program, you're also doing disservice because those strains can be transmitted to other people, and that ends up being more costly to treat as well. So I think that the argument for empiric um, treatment with MDR-TB, I think that this is not done enough. I think that this is frowned upon a lot by MDR-TB experts, but I think from a cost-effectiveness point of view, it ends up being it ends up being cheaper in the long run, both for the patient and for the public health. So, why do you see resistance to H or S before seeing resistance to R and E? And this is historical. So, isoniazid and streptomycin, and really streptomycin was the first drug. So, especially, why do you see streptomycin resistance when this is not even used in your first line treatment for tuberculosis? That was the first drug treated. There were a lot of the streptomycin resistance does come from those early days, so strains that were treated with streptomycin monotherapy, and then with isoniazid monotherapy. Rifampicin and ethambutol, when they were developed and they were included into the short course chemotherapy regimens, there was a much greater understanding of what is required uh, to to effect a durable cure uh, and at the same time prevent the creation of drug resistance. And so there is less, and that's why the foundation is when you have these pre-existing, and pre-existing can be both from the patient's point of view, but from a societal point of view, these pre-existing um, drug resistant patterns, if they are not treated correctly, then further resistance is amplified and you get MDR-TB. Um, and this is now, I think that there are a lot of, I think that this is getting a bit beyond the 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 scope of this talk. I mean, I think the scope of this talk is more about the clinical management of patients. But I think that there are a bunch of questions about what are the public health implications of this. What does it mean to have to be more aggressive about MDR-TB treatment, about being more aggressive about diagnosis of MDR-TB. This will have more create more patients that need second-line TB drugs. This will be a further cost to the program. Other people have said, would you recommend to perform a DST or expert at the beginning of treatment in high burden MDR-TB settings or in HIV positive settings? And actually, I would go beyond that because that currently is the WHO recommendation that in high burden MDR-TB settings where HIV positive patients should receive expert. Um, I would go further that I think that even in the few years that I've been doing TB, there has been an understanding that we need to expand laboratory capacity and not just expand it for retreatment cases for patients who have failed or relapsed one or two or three courses of DOTS regimens, but who are new cases who have never been treated for TB before. And this would prevent a lot of the resistance amplification that goes on through the empiric use of DOTS regimens on pre-existing drug-resistant TB. Does this have implications for the global community, for the aid community, for national TB programs? Absolutely, it does. But I also think that we are losing the battle, that every year that I've been doing TB, every time that they have a report on drug resistance surveillance, there is more, that the proportion of drug resistance and the proportion of MDR and the proportion of XDR TB cases are going up. I think at some point we're going to realize that we need to take we have to take real steps to prevent this cycle of transmission of MDR-TB from continuing. And one of those steps is going to be more access to DST. Thank you very much. I hope that this has been educational, and I hope that I'll be able to see you, all of you, in the field sometime soon.